السلام عليكم ورحمة الله وبركاته. بسم الله والحمد لله والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. اللهم انفعنا بما علمتنا وعلمنا ما ينفعنا وارزقنا علما. My lecture today is about rhabdomyolysis. Rhabdomyolysis, this is done by the surgeon, trauma surgery and acute care. It is mainly related to the recommendation. It's not about strong or weak, but this is related to our practice and to avoid the complication that may happen due to the rhabdomyolysis. My objective during this talking is about definition, risk factor, clinical manifestation, laboratory finding, management, and the complication. We come first of all to know about the definition. What is the rhabdomyolysis? It is a clinical condition. It is characterized by the primary mechanical or secondary metabolic skeletal muscle injury. It is mainly related to the muscle injury, resulting in cell death and release of potentially toxic substances. Such as electrolyte, myoglobin, and sarcoplasmic protein into the bloodstream, resulting in a systemic complication. So this subject related to the complication due to muscle injury, and we have to avoid this complication by our management. Management often centers on prevention or the treatment of the primary complication of the condition, like mainly acute kidney injury. We come to one question: in which patient population should rhabdomyolysis be suspected? Mainly, we know that it is in trauma patient. The recommendation here that we should suspect in the patient with a large burden of traumatic injury involving the muscular tissue, especially patient with crash injury. So mainly those patients after the accidents who coming with long bone crash injury, we suspect the rhabdomyolysis, okay? Mainly, as we saw, that involving the extremities or the mangled extremities. Patient with vascular injury also, or in muscle ischemia with subsequent reperfusion are also a high risk of the rhabdomyolysis. What are the risk factors of the rhabdomyolysis among the traumatic patients? These mainly include many risk factors like patient with multi-system trauma, crash injury involving the extremities or torso. Those with compartment syndrome of one or more extremities, mainly age more than 55 years. So we are most of them are suspected. We have injury severity score greater than 16. There is a score about the injury severity score related to the site of the injury and what is the score. So more than 16 is one risk factors of the rhabdomyolysis. Sorry, Yani, male 6, I don't know why. Because maybe the body, the muscle power is more and the muscle index is more than the female. I don't know, maybe not. Body mass index greater than 30 kilogram per meter square. Patients who fall with subsequent prolonged immobilization are also at higher risk for rhabdomyolysis, mainly those patients in the ICU for prolonged immobilization on the bed. So one of our target is mobilize the patient as early as possible. In the metabolic etiology, we have that rhabdomyolysis should be suspected in any patient with a medical condition causing increased metabolic demands on myocytes in excess of the available supply of ATP. This may result from extreme exertional demands on skeletal muscles from exercise, exogenic agents such as drugs, toxins, genetic defect, or myopathies affecting the muscle cells and the infections. Any process that impair the ATP production by skeletal muscles, any state where skeletal muscles energy requirement exceed the available ATP may lead to rhabdomyolysis. About the exertional cause of the rhabdomyolysis may include, we said that extreme and prolonged exercise, okay? So those who are doing exercise, they have to take care about the time. Seizure activities such as status epilepticus, also one of the causes that can lead to rhabdomyolysis. Most common drugs and toxins can lead to rhabdomyolysis, like alcohol abuse or dependence may actually be the most common risk factors for rhabdomyolysis. Ethanol has direct adverse effect on the muscle tissue metabolism and cellular integrity, including the inhibition of the active transport pump. Other illicit substances such as cocaine, heroin, and phencyclidine may also be implicated in cases of rhabdomyolysis. Those patients who taking lipid-lowering agents also, they have to take care because this can lead to a common cause of the rhabdomyolysis, particularly in patients with concomitant renal or liver insufficiencies. Infection also can lead to rhabdomyolysis, such as influenza, Epstein-Barr virus, Streptococcus, pyogenes, Staphylococcus aureus, and may rarely lead to rhabdomyolysis. Genetic disorders, including disorders of the glycolysis or glycogenolysis, lipid metabolism defect, mitochondrial disorders are rare cause of rhabdomyolysis. Finally, we said that the rhabdomyolysis may be seen in the patient with extreme alteration in the body temperature due to conditions such as malignant hyperthermia, heat stroke, or neuroleptic malignant syndrome. All these is causes, but the main effect of it is the rhabdomyolysis. So we have to care about the diagnosis of the rhabdomyolysis and how we start its treatment. The clinical manifestation. What is the clinical manifestation of the rhabdomyolysis? Its presentation may vary from asymptomatic to commonly implicated clinical features, including acute muscle weakness, pain, tenderness, swelling of the affected extremity or the body region. Also, we can see in the manifestation in the urine, like darkening or what is called tea-colored urine may be an additional common finding. A low threshold of the clinical suspicious in the proper laboratory and historical context is warranted to initiate appropriate therapy. Resultant organ dysfunction may include renal, the effect of the rhabdomyolysis or complication, maybe lead to the acute kidney injury, cardiac arrhythmias, and coagulopathy. So these three main complications of the rhabdomyolysis we have to take care in the ICU for this disease. Common implicated muscle groups are the extremities and the lower back, superficial pressure ulceration or blistering may suggest the diagnosis, but is not a reliable finding. Cannot see. Okay. At the extreme of the pathology, we said that compartment syndrome of the affected muscles group lead to increased morbidity and potential need for decompression. دائما لما الجراحين تعالوا يا جراحين عندي compartment syndrome يقول لك medical treatment. So we have to release all the source of the rhabdomyolysis. What laboratory finding aid in the diagnosis of rhabdomyolysis? The most one is CK. The most common implicated variables include elevated serum concentration of CK, which is more than 5, the upper limit of normal, or more than 1,000 international unit per liters. Also myoglobin, but myoglobin, as we said, from known that it is coming early and going back to its normal early. So we depend mainly on the CK. Lactate dehydrogenase also, potassium, creatinine, and aspartate aminotransferase. Elevated urine myoglobin also provided additional evidence. What is the strategy? Strategy for disease monitoring with a serial CK measurement should be additionally undertaken. Interval CK value should be followed until a big concentration is identified. It mainly taking between 24 to 72 hours. Discontinuing once the CK is reliable downtrending. When we saw that the level of CK become stable and then start to decline, then you have to follow our management or start to decrease the IV fluids and which we come to know. Aside from creatinine kinase level, there is 3 labs patterns may suggest rhabdomyolysis. None of these patterns are 100% sensitive, so they cannot be relied upon to diagnose the rhabdomyolysis. Necrosis of the large quantities of the tissue may cause the following concentration of the electrolyte changes. We have 3 patterns, as we said. Pattern 1 related to the tumor lysis syndrome pattern, which is the hyperkalemia, hyperphosphatemia, hypocalcemia, and elevated uric acid and lactate dehydrogenase level. The pattern 2, which is coming as isolated AST elevation alone, or dramatically elevated AST with minimally elevated ALT, rises equation of AST release from the muscles due to the rhabdomyolysis. Pattern 3, which is urine with positive heme. This is the sensitive of the heme positive. Urine is good. Sensitive is more than 90%. This is a rough classification of the rhabdomyolysis based on the CK level. If we find that there is normal CK level between 400 to 200 units per liter, so nothing is there. There is no any rhabdomyolysis, okay? Mild rhabdomyolysis, it can be between 1,000 to 5,000 international units per liter. There is low risk for kidney injury, and possible treatment possible will depend on the context itself. But about the moderate rhabdomyolysis, when the UK CK between 5,000 to 15,000, this increased risk of renal injury. Here the treatment is, yes, we need to treat the patient. In the severe rhabdomyolysis, more than 15,000, there is increased risk of dialysis, and yes, we need treatment. But according to dialysis or not dialysis, this depends on the situation and the clinical situation of the patient himself. This is a graph about the serial CK value may be useful in some situation. We know that initial CK level is moderately elevated in the beginning, and there is a high index of suspicious for rhabdomyolysis, but the initial CK level is 1,000 to 5,000. Further increase could be indicated in the indicate the need for fluid. So we know here that the CK is coming from 24 hours to up to 72 hours. This is the peak. But the myoglobin, we see that started from 0 time and start to come back to normal within 24 hours. So we depend mainly on the CK. This is about the rhabdomyolysis diagnosis. As we know that signs symptoms, we said that there is muscle pain or T-color urine. If there is like that, we have to check the creatinine kinase level, along with electrolytes, calcium, magnesium, phosphate, and urine analysis. The other picture is high-risk situation for rhabdomyolysis, with mainly patients have with trauma, crash injury, compartment syndrome, extreme exertion, hyperthermia, found down, and intoxication. Also, this is give indication about rhabdomyolysis, so we have to check for the CK. Isolated elevated of AST. If we find the patient have high AST alone without ALT, we have also to look for CK. Suggestive of the urine analysis, if there is heme positive, less than 5, there is the RBCs less than 5. So from where this heme has coming, we have to check for the CK. Evaluation of established acute kidney injury. Yeah, we have also to look for the CK. الآن أنا عملت CK. If the CK is less than 1,000, what I have to do? Rhabdomyolysis current absent, ما عندي. If CK mildly elevated, mechanism of the injury placed, but places the patient at high risk for rhabdomyolysis may repeat. ممكن نعيد الCK خلال كم؟ 8 إلى 12 ساعة. If there is rhabdomyolysis, we say that there is increase in the CK level, because we said in the beginning, CK level would be maximum within up to 48 hours. If the CK is between 1,000 to 5,000, here we have suspected about mild rhabdomyolysis. We come to the clinical significance of this finding. If it is like that, then we have to calculate the McMahon rhabdomyolysis score. This is in the end of the lecture. I can give you about this, the calculation of this score. If the CK is more than 5,000, that means moderate to severe rhabdomyolysis, and we have to go for treatment. Right. The main treatment for this patient will be with fluid resuscitation. Okay, depending on the hemodynamics, where we can see then the another algorithms for this. But if the patient calculate, for example, the Mac-Hon rhabdomyolysis score is less than 6, we have less than 6 and more than 6. This is the cut. If less than 6, we have to lower, and we have lower risk for acute kidney injury. So we have avoid the nephrotoxic medication, avoid give fluid resuscitation if patient is hypovolemic. If concerned, may follow the serial CK labs and Mac-Mahon score. But if the Mac-Mahon score is more than 6, so we have then to go for the definitive treatment. Management, what is the optimal crystalloid type? Of course, the management of the rhabdomyolysis is by giving fluids. Okay, so either lactate ringer solution or saline 0.9 or 0.45% is an acceptable fluid for resuscitation in rhabdomyolysis. Starting rate will be about 400 ml per hour, and very aggressive. Can be initiated starting rate of 400 cc per hour with a range of 200 cc per hour to 1000 cc per hour. This is 400 is the medium. Is considered reasonable, but should be tighter to urine output. Ensuring that the patient is receiving adequate resuscitation without suffering from fluid creep, with goal-directed therapy of urine output of 1 ml per kg per hour to 3 ml per kg per hour and up to 300 cc per hour. This is what about the urine output. Are the diuretics and or bicarbonate administration beneficial? The recommendation, what they said that according to the clinical studies evaluated the efficacy of the sodium bicarb and or diuretics use, mainly mannitol or low diuretics for prevention of the rhabdomyolysis induced acute kidney injury are limited. By the lack of appropriate control groups, standardized definition, retrospective design, and low statistical power. So the recommendation here, given this significant limitation, the use of sodium bicarb or diuretics for the prevention of acute kidney injury in rhabdomyolysis is not recommended. So it is not recommended unless there is indication for the use of the bicarb or the diuretics. Here about the rhabdomyolysis treatment in general. Rhabdomyolysis, as we said, that CK more than 1000 with an indication for volume resuscitation or a Mac-Mahon score more 6 or greater. Here, the clinical evaluation, and we said that we come to hypovolemia, we have to give make the patient euvolemic. Hypervolemia, we have to stop all the diuresis, and like we give him to go another type of treatment like CRRT or something. So this is can be according the main things of the rhabdomyolysis treatment. And we come to another problems with rhabdomyolysis, which is the electrolyte imbalance. It's very important. We said that tumor syndrome, you have to treat the electrolyte imbalance because this can lead to complication. The hyperkalemia, hyperphosphatemia, and hypocalcemia are electrolyte abnormalities most commonly encountered when treating the rhabdomyolysis. Correcting the biochemical equilibrium and electrolyte during the rhabdomyolysis should proceed to avoid complication from the treatment. Hyperkalemia is electrolyte abnormalities that require timely correction to reduce the risk of what? Cardiac arrhythmia, which is very dangerous complication. Potassium level should be seriously evaluated. Patient with high potassium level more than 6 millimole per liter should have cardiac monitoring. ECG should be obtained and assessment for manifestation of severe hyperkalemia, which is QRS, widening, small B wave, and severe arrhythmiasis. طبعا احنا بنتابع الالكترولايتس mainly Q6 hours, Q4 hours. فاذا في عندي hyperkalemia, have to go for aggressive treatment for this hypokalemia to avoid the complication of the cardiac arrhythmias can lead to that. Elevated potassium level also should be treated with insulin and glucose infusion. Consider administration of beta-2 adrenergic agents such as albuterol via aerosol inhalation. Lastly, consider the potassium removal via crushing exchange resin or dialysis as indicated if not responding to the medical treatment. So we have to go to dialysis. So this is what one of the indication of dialysis during the rhabdomyolysis is the hypercalcemia, which is not hyperkalemia, which is not responding to the medical treatment. Potassium. The hypocalcemia also aggravate the electrical effect of the hyperkalemia and should be aggressively treated with calcium chloride or calcium gluconate. Early hypocalcemia treatment in rhabdomyolysis should be avoided in the beginning unless patients are symptomatic or severe hyperkalemia is present. So from the management of the hyperkalemia, we have to give calcium gluconate or calcium to increase the calcium and decrease the potassium. Treatment of the hyperphosphatemia also should be done with caution since treatment involves administration of calcium channels, which can increase the precipitation of calcium phosphate in injured muscles, and that can also lead to the acute kidney injury. Early hyperphosphatemia typically decreases as the phosphate is excreted in the urine. But what is the role of RRT? renal therapy. There is no rule for RRT. Either continuous CRRT or intermittent in rhabdomyolysis to prevent the acute kidney. So there is no rule. The utilization of the renal responding therapy in the patient with rhabdomyolysis should be based on traditional indication for acute kidney injury and the degree of the renal impairment, such as severe acid-base disturbance, electrolyte abnormalities, hypervolemia, all of which are refractory to medical management. So you have to start first medical treatment. If refractory, then you have to go to CRRT. In patients with rhabdomyolysis who developed acute kidney injury and need RRT, either CRRT or intermittent RRT should be used based on the degree of the renal impairment and the clinical status of the patient. But there are no recommendation regarding RRT, renal replacement therapy modalities, filtration versus diffusion, filter type low versus high cut of the membrane, or high flow versus low flow. So there is no recommendation to start one modalities against the other. باقي دقيقتين. طيب. Complication should be suspected. On the clinical should be monitoring for a variety of complication ranging from an asymptomatic elevation of the muscle protein to an accumulation of the electrolyte. Morbidity can present early in late, including hyperkalemia, hepatic dysfunction, cardiac dysfunction, acute kidney injury, acute renal failure, disseminated intravascular coagulopathy, and compartment syndrome. So this is mainly the complication of the rhabdomyolysis. Acute kidney injury is the most common systemic complication of the rhabdomyolysis and is responsible for most of the morbidity and mortality associated with the rhabdomyolysis. Can we predict the score? Yes, we have to predict the score, which we said that this is Macron. This is Macron score. As we said that more than 6, we have to go for treatment. Less than 6, we have to follow the patient. We can come here to who merits Philwitz therapy. According to the Macron, we said that CK less than 5,000 definitely don't treat. Initial treatment, consider stopping therapy in 24 to 48 hours if the CK does not rise over 5,000 and no kidney injury occurs. More than 5,000, we have unclear. وما عندي may treat with lower إذا كان الماكون less than 6. إذا كان الماكون more than 6, we have to go for definitive treatment. The conclusion, which is the home take message, rhabdomyolysis is relatively uncommon but important condition seen in the critically ill and injured patient. The diagnosis is made with combination of the clinical and laboratory finding and should lead to prompt intervention to halt the process causing muscle damage and to prevent or treat the non-complication of the disease. A consequence summary for the diagnosis I can mention in one table after this. Although traditional therapeutics such as urine alkalization and diuresis are often employed in an effort to prevent rhabdomyolysis associated acute kidney injury, evidence-based treatment with outcome beneficial are lacking. So this is the rhabdomyolysis consensus summary. Thank you very much for your support.